in surgery perhaps, in orthopedics perhaps. And that's what makes it exciting. That's what makes psychiatry so much more fun and challenging, because there aren't any sort of, it's not a broken head of femur that you either replace, or you put a plate, or you replace the head of femur, or you look at the x-ray and you see whether the screws are in the right place. And it is, you look at certain decisions you previously made, and you have a kind of cross index in your mind, and then you apply that to the new decision making. And we are constantly told in our training that don't ask closed questions. Ask open-ended questions so that you don't get into this premature closure. And there in psychiatry, more than anything else, the difference in power between the clinician and the patient is tremendous. We as psychiatrists have the power of taking people's liberty away. So the interaction is very different, and we need to bear that in mind. And how do we make these unconscious judgments into clinical decisions? And when I got interested in this area, how we make decisions, I asked a number of colleagues to look at two things. One is, how do you make decision in a complex clinical setting? The last difficult patient you saw, how did you make a decision in diagnosis and in management? And at the same time, tell me the decision you made when you bought something very expensive, a house or a car. And it was absolutely fascinating, and I'll come back to that most people, when they talk about buying a car, they look at the make, they look at its history, they look at the color, they look at the horsepower, they look at what others have said. Similarly, in-house, you look at the location, you look at how many bedrooms you need, who else is going to be around, do you want to be close to your mother-in-law, do you want to really go as far away as possible? Or you decide on a number of other factors, you read a magazine, you read a review of the location, etc. And normally in clinical settings, we generate between 4 and 7 hypotheses. We can't generate more than 7. So if you ask a medical student or a clinician, give me a differential diagnosis, generally 3 or 4 conditions. It's very rarely that you will get 10 conditions, no matter what the problem is. I'm going to sort of skip that. Dual process theory is that there are 2 cognitive processes going on in our clinical reasoning. One is analytical and the other one is intuitive. Pattern recognition determines intuitive, and automatic decision then sort of looks at analytical patterns. So we looked at the study. This was published in Acta Psychiatrica Scandinavica last year, so if you want details. So we did a purposive sampling of psychiatrists of various nationalities, gender, ages, experience. I did the interviews myself, recorded the interviews lasting between 30 and 90 minutes. We transcribed them verbatim and analyzed. As I said, the 2 things was most recent difficult case they had seen and how they reached a decision, comparing it with last expensive purchase. And we then did a 5-stage process of analyzing the qualitative data, familiarizing ourselves, looking at themes, then indexing the themes, charting and mapping how many times those themes were emerging, and this was all done by a trained anthropologist. So there were 4 broad themes emerged. One was overall approach to psychiatric practice, perceptions of clinical and management decision making, perceptions of difficult clinical and management decision making, and differences between novices and experts. Of the 31, I think I had recorded about 40-something interviews, but we sort of analyzed 31. Of the 31, only one clinician mentioned evidence-based decision making. 30 talked about gut feeling, this is how I've been taught, this is how my boss did it, this is what my training taught me. And that raises some very interesting questions about the role of evidence-based practice and how do we make it part of the decision-making process. So looking at those 4 frameworks, 7 themes emerged: how we gather information, our training, our intuition and experience, evidence-based practice, cognitive reasoning, and uncontrollable factors, and incredibly important that if you're working in a multidisciplinary team, how do you change your decisions? So it was very clear that information gathering was not systematic, investigations were not routine, medical routes were sometimes followed, sometimes not, and other sources were used: case notes, GP's letters, talking to the GP, information from relatives. And that is much more complex when you look at comorbid conditions. When talking about training in psychiatry, it was all about mentors and teachers models rather than their own, which was sort of medical and biopsychosocial. Clinical intuition was focusing very much on risk assessment. Is this person at risk? Is this person at risk to self, or is this person at risk to others? And how do you avoid uncertainty? Psychiatrists, by and large, are very good at dealing with ambiguity. We can cope with it much better than surgeons can. But how do we deal with that uncertainty, and how do we avoid that? And no 2 patients of schizophrenia are alike. They're not. They may have delusion to the content, the degree and response would be very, very different. Evidence-based practice is about sort of being aware of the guidelines and limitations, but it's also patient variation. And if patients behave themselves, we would be a very happy lot. Patients don't, for all kinds of reasons. They take their medication regularly, but they take it at different times, with different other medications that we don't know about, with different diets, with other rituals. So there are a whole load of other problems. So cognitive reasoning in this context is about hypothesis testing and trial and error. Uncontrolled factors are about social pressure on the patient and the clinician, and that's where cultural differences come in dramatically. And it's about institutional factors and requirements. And we heard earlier about paying to see the consultant or paying to see the psychiatrist. That has different expectations, and therefore the clinician also has different expectations in making those decisions. Do I want this patient to get better? Yes, because he will go and tell 10 other people who will then come and see me. Maybe. So it is also about accessibility and availability. And I've talked about multidisciplinary teams and quite often uncertainty from different disciplines, different models. And how do we as clinicians try and bring it all together and deal with that conflict in making those decisions? So there are problems in this study, and it's a very small size, but qualitatively it's a sizable number, and it is about personal experiences, which is incredibly important, and it is about the things that we need to bear in mind when we look at decision making is about time pressures. When I was training, one of the consultants I worked with would not do a ward round till the patient had been on the ward for 6 weeks. And after 6 weeks, we all had to present, and he would discuss one patient for 5.5 hours. Now that's a kind of completely different way of decision making than if you're sitting in an outpatient and you've got 5 minutes consultation. And it is how do we kind of make sense of the intuition, and how do we build on it? So to conclude, I think there are differences between novices and experts in making decisions. I certainly, when I started doing psychiatry, I was much more confident in making decisions and diagnosis of schizophrenia than I am now. I'm much less certain about diagnosis because I can look at all kinds of other factors. More patients you see, easier it gets. It certainly makes a major difference in dealing with uncertainty and dealing with risk. So thank you very much for inviting me. Thank you for giving me the opportunity, and I do apologize if I'm keeping you from your dinner. Thank you.
Thank you, Professor Denish Kubra, and I'd like my colleague, Professor Mustafa, to start the discussion.
Any question?
I'm strongly in favour of evidence-based practice, but I suppose the more experience I get, the more I feel that intuition is actually really quite important. The problem is, how do we actually train them? How do we train people with regards to the intuition if what we're doing is relatively unconscious? Experience, you said in your last slide, or second to last slide, is an important thing, but beyond simply experience, because I see trainees with the same amount of experience, some have got great intuition, some are absolutely rubbish.
I agree with you entirely. I mean, the trick and the bit that we haven't built into our training system is about critical thinking, having the time to sit back and reflect. Balanced groups used to be very good for that in training in the UK, and I don't think they happen anymore. For various reasons, they've been cut down, cut out. Part of the challenge for me as a trainer is the supervision that I give is for the trainee to use that as a reflection. Now, it's not perfect, but I think you've got to start somewhere. And I am with you that, because psychiatry is such a wonderful subject, the experience is very, very different. So, same patient seen by two different trainees will be seen very, very differently.
Any female interest in complexity of decision making? Any questions?
One of the main factors of wisdom is tolerance of uncertainty. And you're asking a psychiatrist to be uncertain. I think uncertainty comes with more knowledge, more clinical experience. But when you are young, you are quite sure.
Look, that's the difference between young surgeons and old surgeons as well. Experienced surgeons may take the opportunity and say, let's wait. The young surgeon will say, right, let's go and open it now.
Okay. We have one last question because we have to close. People are fighting outside for the last question. Yes.
Sami? Sahad? Yes, please.
Thanks very much. Yeah, just one idea just I want to talk about. There is, of course, there is no ideal solution for such uncertainty. Measurement-based care is one thing that I believe is would be helpful also. The second thing also, like trying always to be humble and in following, the right way to make decision. Sometimes people, after some time of practicing, start to think that they are experts. They can just make, they can smell the diagnosis or this stuff. So applying evidence-based medicine always, and also in selective cases, challenging cases, to be humble, to allow for case presentation, to allow others to share, to have a second opinion. That would be helpful as well.
No, I agree with you. I think we need both measurements to produce outcomes and be very clear as to what we are measuring. Not because everybody else is doing it and therefore we should do it, otherwise it just becomes a tick box exercise. And you're absolutely right. I agree with you.
Okay, thank you very much. On behalf of everybody here, we'd like to thank you for being on time, although we started late. And there is a souvenir and gift for you from the organizing committee and from SG Hospital. Okay. This is for Dr. Karim.
شكر خاص رئيس الجلسة الدكتور مهدي أبو الدين.